What if the pill your doctor has been prescribing you for years, the one sitting on your nightstand every single morning, is not fixing your blood pressure problem but quietly making it worse? That might sound impossible. After all, your doctor prescribed it. It must be working, right? But here is the question nobody in that exam room is asking. Why are millions of people on blood pressure medication for decades still having strokes, still suffering heart attacks, still waking up dizzy and exhausted, while their prescription keeps getting refilled without a second thought? Today we are going to pull back the curtain on one of the most commonly prescribed classes of drugs in the entire world, and I am going to walk you through what the research actually says, what is happening inside your body, and what you absolutely need to know before you take another pill. Let's start with the basics, because this matters more than most people realize. When your doctor says your blood pressure is high, they are measuring two numbers. The top number, called systolic, reflects the pressure in your arteries when your heart beats. The bottom number, diastolic, is the pressure when your heart is at rest between beats. A reading above 130/80 is now considered elevated by most major health guidelines, and the moment those numbers creep up, the reflex in most medical offices is the same reach for the prescription pad. The most commonly prescribed medications for this are a group called ACE inhibitors, calcium channel blockers, diuretics, and most commonly of all, a class called beta blockers. And it is beta blockers that we need to talk about most seriously today, because they are prescribed not just for blood pressure, but for anxiety, heart rhythm problems, migraines, and more, yet the evidence behind their use for uncomplicated high blood pressure in otherwise healthy people has quietly been unraveling for years. Here is how a beta blocker works. Your heart responds to adrenaline, a stress hormone, through receptors on its surface called beta receptors. When adrenaline floods those receptors, your heart beats faster and harder, and your blood pressure shoots up. Beta blockers literally block those receptors. They stop adrenaline from doing its job. Your heart slows down, it beats with less force, and as a result, the pressure in your arteries drops. On paper, that sounds like exactly what you want. But here is where the story gets complicated, and why millions of people are suffering side effects their doctors are dismissing, or worse, prescribing another drug to manage. When you block adrenaline receptors in the heart, you are not just blocking them in the heart. Beta receptors exist throughout your body. They are in your lungs, which is why beta blockers can trigger breathing problems and even worsen asthma. They are in your pancreas, which is why beta blockers can interfere with your blood sugar regulation and increase the risk of developing type 2 diabetes, a finding now supported by multiple large-scale studies. They are in your brain, which explains why one of the most common and underreported side effects of beta blockers is depression, fatigue, brain fog, and a flattening of your emotions. Patients describe it as feeling like they are living behind a sheet of glass. Everything feels muted, distant, slower, and when they bring this up to their doctor, they are often told it is just anxiety or stress or aging. They are not told that their blood pressure pill may be chemically dampening their central nervous system. There is also the issue of sexual dysfunction. Beta blockers significantly increase the risk of erectile dysfunction in men and can reduce libido in both men and women. This is not a rare side effect listed in tiny print on a pamphlet. Studies have found rates of sexual dysfunction in beta blocker users that are dramatically higher than in people taking other classes of blood pressure medication. And yet many doctors never mention it during the prescription conversation. Patients notice it, they feel it, and they often feel too embarrassed to bring it up, so they suffer in silence, sometimes for years, not connecting it to the little white pill they take every morning. Now let's talk about something even more troubling, the evidence, or lack thereof, that beta blockers actually reduce the risk of heart attack and stroke in people with ordinary high blood pressure. This is the entire point of treating blood pressure in the first place. We are not just chasing a number on a cuff. We are trying to prevent catastrophic cardiovascular events. And here is where the research is genuinely alarming. A major systematic review published in the respected medical journal The Lancet looked at the evidence for beta blockers as a first-line treatment for hypertension and found that while they do lower blood pressure numbers, they do not reduce the risk of stroke as effectively as other drug classes. In some analyses, they were actually associated with a higher rate of stroke compared to other antihypertensive medications. The blood pressure number looked better on paper, but the outcomes, the thing that actually matters, were not improved and sometimes were worse. Why would that be? It comes down to how beta blockers lower blood pressure compared to other medications. Other drug classes tend to lower the pressure throughout the entire arterial system, including in the central arteries close to the brain. Beta blockers primarily work by slowing the heart rate and reducing how hard the heart pumps, but they are less effective at reducing the stiffness and pressure in those central arteries. So your reading at your arm might look normal, but the pressure your brain is experiencing could still be dangerously high. This concept, called central aortic pressure, is something most routine blood pressure checks do not measure, and it may explain why beta blocker users can look well controlled on paper while still suffering the complications of uncontrolled pressure internally. Let us also address the weight issue, because this one surprises almost everyone. Beta blockers are associated with weight gain. Not in every patient, not always dramatically, but the mechanism is real and documented. When you blunt adrenaline's effect on the body, you also reduce your metabolic rate, the speed at which your body burns calories. You feel more tired, you exercise less, because even mild exertion feels more difficult when your heart rate is artificially suppressed and your body stores more of what you eat as fat. This creates a vicious cycle because weight gain itself raises blood pressure, meaning the very medication you are taking to lower your blood pressure may be contributing to the underlying problem over the long term. And then your doctor sees your pressure creeping up again, and the answer is, you guessed it, a higher dose or a second medication. This is the pattern that has to be confronted honestly. The medical system is designed around managing disease, not reversing it. When you walk into a clinic with high blood pressure, the path of least resistance for both you and your physician is a prescription. It takes 7 minutes. The pill is covered by insurance. You walk out feeling like something was done, but what was actually done? The number was addressed, the cause was not touched, and the side effects are now added to your daily experience of life, quietly degrading your energy, your mood, your body composition, and sometimes your cardiovascular health in ways that will not show up on a routine check for years. Now, I want to be absolutely clear about something. I am not telling you to stop taking your medication. Do not do that. Abruptly stopping a beta blocker, especially if you have been on it for a long time, can cause rebound hypertension, a sudden and dangerous spike in blood pressure, and can trigger serious cardiac events. If you want to come off a beta blocker, that has to be done gradually under medical supervision with a plan in place. What I am telling you is that you have the right to ask your doctor hard questions. You have the right to understand why a specific drug was chosen for you, what the evidence is behind that choice, and whether there are better tolerated alternatives that might give you the same or better protection with fewer side effects. And there are alternatives. The drug classes that currently have the strongest evidence for reducing stroke and heart attack risk in uncomplicated hypertension are not beta blockers. They are thiazide diuretics, which help your kidneys eliminate excess sodium, and water and calcium channel blockers, which relax the walls of your blood vessels, and ACE inhibitors or ARBs, which block the hormonal pathway that constricts your arteries. These classes have a more robust evidence base for actual cardiovascular event reduction in people without pre-existing heart disease, and many of them have a more tolerable side effect profile for the average person. Beta blockers do have a firm and important place in medicine for people who have already had a heart attack, for people with certain rhythm disorders, for people with heart failure. But for someone who simply has high blood pressure with no other complications, they are increasingly seen by cardiologists themselves as the wrong first choice. Beyond medication, let us spend a moment on what is actually driving the blood pressure epidemic in the first place, because this is where the real power lies. The single most powerful dietary intervention for blood pressure is reducing sodium. Not to zero, your body needs sodium, but the average person in the modern world is consuming 2 to 3 times the amount their cardiovascular system can comfortably handle. Most of that is not coming from the salt shaker. It is coming from processed food, canned goods, restaurant meals, and packaged snacks. Reducing sodium intake alone has been shown in large trials to lower systolic blood pressure by as much as 5 to 10 points, equivalent to the effect of a low-dose medication with 0 side effects. Combine that with increasing potassium through vegetables, fruits, and legumes, and you begin to shift the entire electrolyte balance that governs arterial tension. Physical activity is the other pillar that is so powerful and so underutilized. Aerobic exercise, walking, cycling, swimming, anything that gets your heart rate elevated for 30 minutes most days, reduces resting blood pressure through multiple pathways. It makes your arteries more elastic. It reduces the activity of the nervous system that constricts blood vessels. It helps regulate your weight and insulin sensitivity. The effect sizes in clinical trials are not trivial. Regular moderate exercise can lower blood pressure by values that rival medication without the fatigue, the brain fog, or the metabolic consequences. And yet, how many patients walk out of a hypertension appointment with an exercise prescription? Almost none. The prescription pad is faster. Sleep is another factor that deserves serious attention and almost never gets it in a 10-minute appointment. Chronic poor sleep, whether from insomnia, stress, or undiagnosed sleep apnea, is one of the most powerful drivers of elevated blood pressure that exists. Sleep apnea in particular, where breathing repeatedly stops during the night, causes surges of adrenaline and cortisol that directly raise blood pressure, and no amount of medication fully corrects pressure that is being driven by a structural breathing problem. If you snore loudly, wake up feeling unrefreshed, or have a partner who tells you that you stop breathing in the night, getting a sleep study is not optional, it is essential. Treating sleep apnea sometimes results in blood pressure dropping so significantly that medications can be reduced or eliminated entirely. Stress and the chronic activation of your body's fight or flight response is the final piece that medicine rarely has the time to address properly. Cortisol and adrenaline, when chronically elevated because of work pressure, relationship conflict, financial anxiety, or unresolved trauma, keep your arteries in a state of sustained tension. Practices that genuinely activate the parasympathetic nervous system, deep breathing, mindfulness, meditation, time in nature, adequate rest are not soft suggestions or alternatives to medicine. They are measurable interventions with real physiological effects on arterial pressure that have been validated in peer-reviewed research. They take longer than a pill. They require consistency, but they address the cause, not just the consequence. Here is the bottom line, that everything we have discussed today comes back to high blood pressure is a serious condition that genuinely increases the risk of stroke, heart attack, and kidney disease, and it should not be ignored. But the way it is most commonly managed, a prescription filled without a conversation about root causes, without a discussion of side effects, without a plan for lifestyle change, and without re-evaluation of whether that specific drug is the best choice for that specific person, is failing millions of people. Beta blockers are not inherently evil drugs. They save lives in the right context. But being reflexively prescribed to every person with a blood pressure over 130 as the first and only line of defense, and then refilled automatically year after year without reassessment, is a pattern that deserves scrutiny, and your health is worth more than a 7-minute appointment. The most important things to take from today: if you are on a beta blocker for uncomplicated hypertension, talk to your doctor about whether it is truly the best option for your specific situation, and ask whether there is evidence it is actually reducing your risk of stroke and heart attack, not just lowering a number on a cuff. Do not stop your medication abruptly. Explore the lifestyle interventions that have real documented measurable effects on blood pressure, and advocate for yourself, because no one else is going to sit in that exam room and ask the hard questions for you. If you found this video valuable and you want to protect your own health with real evidence-based information, please subscribe to this channel, hit the like button so more people can find this content, and drop a comment below telling me what health topic you want us to tackle next. Your questions drive everything we cover here, and I will see you in the next one.